Okay, so we're going to move on now to the last of the three fractures in the transverse family. And as we've seen, the T-shaped fracture is part of the transverse family where the primary fracture line is the transverse fracture. And so the transverse fracture will separate the acetabulum into an intact ilium component, or a roof component, if you wish to think about it that way, and the lower component, which is the ischiopubic segment. And so with the T-shaped fracture, this component can still be transtectal, juxtatectal, or infratectal, as with any of the transverse family. But in this case, we now have a secondary vertical fracture line that divides the ischiopubic segment into an anterior component, or an anterior column component, and a posterior column component. And so those are typically referred to as the pubic component and the ischial component of the T-shaped fracture. Now, typically, this stem of the T, this vertical component, divides the roof of the obturator foramen and then divides the ischial ramus. And in the study of T-shaped fractures in Letournel's book, this comprised the most common T-shaped fracture. However, there are anterior and there are posterior variants. And so the anterior variant, you can see down here in the bottom left, has a fracture that can involve sometimes the body of the pubis or just adjacent to or even extending into the symphysis pubis. And the posterior or ischial T-shaped fracture has a fracture line that skirts the obturator foramen and exits the posterior border of the bone, usually through the ischial tuberosity. And we can see that on the 3D scan on the bottom right. Now, if you look at the schematic drawing of the ischial T, you can see that it resembles the transverse posterior wall. And in fact, you can read in Letournel's book where he discusses the controversy about why this is not included as a transverse posterior wall fracture. And his rationale for this was that because this fragment included all of the posterior border of the bone of the greater and lesser sciatic notches, as well as the cotyloid fossa and all of the posterior articular surface, that it was more appropriate to consider this to be a T-shaped fracture. And so this is what we term the ischial T-shaped fracture. So the radiographic features are simply those of the transverse. So again, we would have the iliopectineal and ilioischial lines disrupted, and the roof may be involved or preserved dependent upon the location of the transverse. So the transtectal transverse would involve the roof shadow, whereas the juxtatectal and infratectal T-shaped fractures would preserve the roof shadow. But there will always be a segment of the roof which is intact to the iliac wing, helping us distinguish this from the any type of associated both column fracture. The transverse component in a T-shaped fracture is always displaced. I think there was only one case of a non-displaced T-shaped fracture in Letournel's series. And the stem of the T is typically, as a secondary fracture, less displaced, or can be less displaced than that of the transverse component. So the radiographic features of the stem of the T, the most clearly seen feature will be that of the ischial ramus fracture. And so we look for that when we think we have a transverse fracture in order to see that there might be a T-shaped component to it. You will also very frequently see a separation of the iliopectineal and ilioischial line. If you look at this example on the right, you can see how both are clearly disrupted, but they're also clearly separated in relation to each other. You may also see a disruption of the two limbs of the teardrop, as we can see here, where a portion of the teardrop is with the anterior column component and a portion of the teardrop remains with the posterior column component. The fracture line that exits through the cotyloid fossa into the obturator ring can be difficult sometimes to pick up on plain radiographs, although we will see it usually on the obturator oblique view. But it is very easily seen on the axial CT scan, as we can follow the stem of the T down into the obturator foramen and then through the ischial ramus. Now, a T-shaped fracture can also be associated with a posterior wall component, And at least in Latronel's book, this recognized subgroup, that of the T-shaped fracture with posterior wall, is actually included in the transverse posterior wall family rather than in the pure T-shaped fracture pattern. Now, one of the things that comes up, which can be quite difficult radiographically, is understanding the difference between the T-shaped fracture and a fracture we'll talk about a little bit later, which is the anterior wall posterior hemitransverse. As you can see, both have an anterior component and a posterior aspect of a transverse. The difference being here that the anterior wall plus posterior hemitransverse fracture that we see on the right is not associated with an ischial ramus fracture, and there's a double disruption of the iliopectineal line. So we have a disruption of the iliopectineal line in the upper part of the pelvic brim, in the more cranial aspect of the anterior wall, and then also lower where the fracture comes across the root of the superior pubic ramus, as opposed to the T-shaped fracture where we will see an ischial ramus fracture. And we typically will see a higher exit point for the transverse into the greater sciatic notch than we will see with the anterior wall posterior hemitransverse, where the posterior column component is a secondary fracture line. This is just a quick 3D to compare the difference between the T-shaped fracture and the anterior wall posterior hemitransverse. And you can clearly see that the predominant fracture line here is the anterior wall component of the posterior column or posterior hemitransverse is a secondary and less displaced fracture line, as opposed to the T-shaped fracture, where the primary fracture line is the transverse and the secondary fracture line is the stem of the T. With a T-shaped fracture, the femoral head will almost always follow the displacement of the posterior column, whereas with an anterior wall posterior hemitransverse, the femoral head will typically follow the anterior wall component in a more anterior medial displacement direction. So when we talk about T-shaped fractures, this is actually probably a fracture that causes people the most to spend the most time in considering what's the appropriate choice of approach. Because in theory, you can approach a T-shaped fracture from a posterior approach alone. You can approach a T-shaped fracture from an anterior approach alone. You can approach it from simultaneous anterior and posterior approaches. You could approach it with sequential anterior and posterior approaches with a direct reduction and fixation of each column individually, or you could utilize an extensile approach. And so the question is, if we're going to try and choose between all of these various options, is it just surgeon's preference, or is there something that guides us in determining our surgical approach? And I think the two critical things to remember here is that when you consider a T-shaped fracture, the posterior column displacement is typically more significant than that of the anterior column. The reason for this is, one, the femoral head is typically following the posterior column fracture. And if you look down at the line drawing of the T-shaped fracture, you can see that the posterior column component is a free-floating fracture fragment. It's not remaining attached to anything, whereas the anterior column component of the T-shaped fracture remains attached to the symphysis pubis in most cases. Therefore, you have a hinge point for the anterior column fracture, whereas you do not typically have that for the posterior column component of this. And so the advantage of approaching this from the back is that you can do a direct reduction of the posterior column component, which is the more free-floating and greater displaced fracture. And you can do a more indirect reduction of the anterior column component by hinging it on the intact symphysis pubis. That is, if the symphysis pubis is intact. Now, unlike some of the other fracture patterns that we looked at last week, here, a T-shaped fracture is definitely facilitated by positioning the patient prone. And I think that goes for all of the transverse family of fractures. It facilitates working through the greater sciatic notch, which is a necessity, and particularly where we're trying to manipulate an anterior column from the back by working through the greater sciatic notch, we really need to maximize our exposure. And so prone positioning will help us safely maximize the exposure of the Coker-Langenbeck. We also are going to need to be able to directly reposition the femoral head, and so we will need either distal traction or lateral traction or a combination of both in order to position the femoral head under the roof so that we can proceed with the reduction and fixation of the T-shaped fracture. Usually the typical reduction sequence is that we will attempt a reduction of the anterior column. So we can do that by either displacing the posterior column and working sort of through the stem of the T-shaped fracture to gain the reduction of the anterior column, or we can work around the posterior column fracture through the greater sciatic notch. In either case, we're going to assess the reduction of the anterior column by palpation of the anterior column component on the quadrilateral surface, plus or minus visualization of that portion if that fracture line is very posterior and can be seen when the posterior column is displaced. But we're really going to rely on a fluoroscopic assessment of the reduction at the pelvic brim and the anterior articular surface, as well as a fluoroscopic assessment of the anterior rim. We would then fix the anterior column if we can get it reduced with screw fixation that goes both perpendicular to the anterior column component as well as perhaps neutralization screw fixation long down the anterior column. And then we would proceed with reduction and fixation of the posterior column component. You can see here these intraoperative fluoro shots here. We have a Schanz pin helping to manipulate the posterior column in place. We have a angled, or helping to, in this case, rotate or displace the posterior column so that an angled jaw clamp can be placed through the greater sciatic notch to reduce the anterior column component. We're looking fluoroscopically and saying that the pelvic brim and the anterior rim and anterior articular surface appear to be reduced in that situation on the left-hand side. And this is really where some type of a quadrangular angled clamp to work through the greater sciatic notch is pretty much mandatory. And then oftentimes we'll use a lag screw technique to try and bring the anterior column in place if that screw is placed perpendicular to the anterior column component. You can see here lag screw technique being placed with a screw being tightened to aid in the reduction rather of the anterior column component of the T-shaped fracture. So here we can see a T-shaped fracture with a significant displacement of the posterior column. There's actually a segmental fracture of the posterior column separating a segment of the greater sciatic notch separately from the remaining portion of the posterior column. And then a lesser displaced anterior column component. We can see here on the Judet views the significant displacement of the posterior column with the femoral head following the posterior column, and then the to a lesser extent, the displacement of the anterior column. We can also appreciate that this is a transtectal T-shaped fracture. The CT scan on the axial views helps us see the division, the separation between the anterior and posterior columns with the femoral head following that posterior column fracture line. And this is approached all through a Coker-Langenbeck with the reduction technique that we spoke about, reducing the anterior column and placing lag screws that are perpendicular to the anterior column first. That's why we don't have screws that are going long down the anterior column because they're not perpendicular to a transtectal transverse component in the anterior column. And then a plate fixation close to the greater sciatic notch. Because of the segmental nature of the posterior column fracture, 2 plates were used posteriorly on the retroacetabular surface. And we could see the reduction of that segmental posterior column is not quite perfect up there at the greater sciatic notch. And the reduction of the anterior column, a little bit difficult to assess there on the obturator oblique. This is a radiograph at 2 years with the patient having a essentially normal radiographic and clinical outcome from his T-shaped fracture. So if we're unable to reduce the anterior column, what we need to do is first, we need to make sure that we didn't screw up and place any fixation that might be blocking the anterior column reduction. As you can see here, I have a lag screw that was placed across the posterior column that was interfering with my anterior column reduction. But if we're unable to reduce the anterior column, we're going to have to reduce and fix the posterior column. And then, as we can see here, with a posterior column is fixed with really provisional fixation. So we haven't fixed the posterior column with our definitive fixation yet, but it's stable enough now that we can reattempt the reduction of the anterior column. And so now we're going to reattempt the reduction with the angle jaw clamp again placed onto the pelvic brim portion of the anterior column, and then a lag screw that is placed perpendicular to the anterior column that enables us to close that small residual gap and reduce the anterior column. And now we can go ahead and change our posterior column fixation to a more definitive fixation construct for the posterior column component. Finally, though, if we're unable to reduce the anterior column of the T-shaped fracture, we're going to have to bail out. We're going to have to leave our posterior column fixation intact, make sure that none of our fixation is crossing the stem of the T, and then we would perform a sequential anterior approach to reduce the anterior column component. Here we can see a transtectal T-shaped fracture, and this one is complicated by the fact that we have a medial fracture of the superior pubic ramus and a segmental fracture of the ischiopubic ramus, as well as an external rotation through the ipsilateral sacroiliac. We know that this is going to be a little bit more difficult situation, and we can see here again the transtectal nature of the fracture, as well as the segmental fracturing of the anterior column component and the posterior column component at the ischial ramus. And so in this situation, an attempt was made at the anterior column reduction, but because of the comminution and the segmental nature of it, it was not possible to reduce the anterior column. And so the posterior column is reduced and fixed, as you can see here, and make sure that none of the fixation crosses into the anterior column, and then perform a sequential anterior approach for the reduction of that anterior column fracture line, anterior column component of the T, with fixation to cross the superior pubic ramus fracture medially. And the Judet views that we can see here, showing the concentric reduction of the femoral head in the acetabulum. So when would we not choose a Coker-Langenbeck primarily for a T-shaped fracture? Well, the main time is going to be when we have associated pelvic ring injuries. And so if we have a symphysis dislocation, now that means that the anterior column component of the T-shaped fracture is now a free fragment, and we would not expect that we would be able to hinge it in from a Coker-Langenbeck approach. Or if we have a sacroiliac dislocation or a displaced sacral fracture, we're going to need to reposition the ilium in space first. And so that may require an open reduction of the posterior pelvic ring in order to bring the ilium in place so that the roof is in the correct location, so we therefore can proceed with our reduction of the T-shaped fracture. Other times we wouldn't choose the Coker-Langenbeck initially is when we have anterior column comminution, particularly at the pelvic brim, which is going to prevent our assessment or reduction attempts from the Coker-Langenbeck approach, or where there's primary displacement of the anterior column over the posterior column, which is a very unusual situation. So just a quick example here of a T-shaped fracture. This is a juxtatectal T-shaped fracture with an associated sacroiliac joint dislocation, which is irreducible. You can see here on the inlet view the dislocation of the sacroiliac joint, as well as the displacement of the T-shaped fracture, and there are contralateral ramus fractures that we can see as well. And so this was approached first with a prone open reduction of the sacroiliac joint, clamp placed through the greater sciatic notch, iliosacral screws placed for the sacroiliac joint dislocation, followed by then a prone Coker-Langenbeck approach for the reduction of the T-shaped fracture all through the Coker-Langenbeck approach. Now, this could potentially have been approached from an anterior approach, but the irreducible nature of the sacroiliac joint dislocation made me favor a posterior approach for the SI joint. We can see here the 4-year follow-up after removal of the iliosacral screws. Here's a T-shaped fracture with an associated posterior wall and also an ipsilateral sacroiliac joint dislocation. And so now we have a situation that sets up very nicely for a staged anterior approach that allows us to reduce the sacroiliac joint dislocation, fix that, and reduce and fix the anterior column component with a provisional fixation, and then perform a Coker-Langenbeck as a secondary surgical approach for the reduction of the posterior column and posterior wall component. And here we can see the patient at a 3-year follow-up with some heterotopic ossification in the abductors, which did not cause a clinical result or significant deficit. One last time when we wouldn't choose a Coker-Langenbeck initially here is a T-shaped fracture, transtectal T-shaped fracture with comminution at the pelvic brim. And so we see this fragment here from the pelvic brim. This is going to remove our ability to palpate a reduction of the anterior column and also maybe prevent us from placing a clamp at the pelvic brim in an appropriate location for the reduction of the T-shaped fracture. In addition, we have a posterior wall component, so we know we are going to need to have a posterior approach at one point. And so here again, we approach this sequentially with an anterior approach to reduce the anterior column component because of that comminution along the pelvic brim, followed by a posterior approach for the posterior column component. And you can see that when sequential approaches for T-shaped fractures are performed, it's very common to end up with a displacement through the stem of the T. And that's why we see that gapping at the ischial ramus and that gapping at the roof of the obturator foramen, although there is a small bending wedge of comminution there. But that's a very typical outcome that we will perform the reduction cranially on the T-shaped fracture, but caudally we will see that gapping, implying to us that the reduction of the columns to each other is not exactly correct. So in summary, most T-shaped fractures are amenable to operation through a prone Coker-Langenbeck approach. The reduction of all transverse family fractures, I think, is facilitated by prone positioning. But remember that a secondary surgical approach may be necessary for T-shaped fractures if there's an associated pelvic ring injury or an inability to reduce the anterior column. We have about, we had some time set aside to sort of summarize all of the fractures that we've talked about here, and last week rather, and this week. And so, as you can see, these fracture patterns, these 6 fracture patterns, are generally considered to be sort of a posterior group of fracture patterns because they are most commonly operated from posterior approaches. Not always, but most commonly. And so, if we remember from last week, we saw discussions of the posterior wall fracture and the posterior column plus, as well as posterior column plus posterior wall fractures. And so Dr. Krieger told us last week that the posterior wall fracture could be approached through a Coker-Langenbeck approach or through a Gibson approach. And this applied to the posterior column or posterior wall fractures as well, although most of those are typically approached through a Coker-Langenbeck. For all 3 of these fractures, prone positioning may be advantageous, but lateral positioning is certainly an option. And the surgeries, the Coker-Langenbeck or the Gibson, can be performed with or without a fracture table. Exceptional posterior walls, particularly those that are high cranial or anterior, might benefit from a digastric osteotomy performed as a component of either a Coker-Langenbeck or a Gibson approach in order to facilitate increasing the anterior exposure that is necessary for some of these very high cranial posterior wall variants. And then today, as we've heard, the transverse family of fractures are most commonly operated through a Coker-Langenbeck, but if associated with displaced pelvic ring injuries, it may alter our primary surgical approach, and certain T-shaped fractures may require 2 approaches or an extended approach right off of the bat. What I wanted to do now is just take a minute or 2 to have you take a look at this X-ray. All right, here's the AP pelvis X-ray. Here's the obturator oblique view. And here's the iliac oblique view. And I'm going to go back to the AP pelvis. Okay. And I'm going to ask you now, Angel, this would be the time to go ahead and put up the question. We're going to ask you, now you can drag on your computer, you can move the pole window off of the X-ray. Just grab it by the gray part at the top and move it off of the X-ray so that you can see the X-ray. And I'd like to ask you to classify this fracture. And obviously it's going to be one of the 6 fracture patterns that we talked about either last week or this week. So go ahead and select, please, the posterior wall, posterior column, posterior wall, transverse plus posterior wall, or T-shaped fracture. Here, there's our obturator oblique view again. So that's fantastic. 87% of you selected transverse posterior wall. Some people selected posterior column, posterior wall, and some T-shaped fracture. You close that, Angel. So if we look at the obturator oblique, we see that we do not see a fracture of the ischial ramus, and so that would rule out for us the T-shaped fracture, and we see a disruption of the iliopectineal line, which is the anterior column extension of the transverse fracture, and so this would not be a posterior column plus posterior wall fracture. And so the vast majority of you were correct in selecting transverse posterior wall. We can show you now some cuts of the axial CT, which confirm our diagnosis. And we have cuts then through the roof of the obturator foramen and the ischial ramus to confirm that there's no fracture there. And so we have confirmed our diagnosis, which is that of a transverse posterior wall. Now, I would just ask you one other thing. If you could bring up the other poll question to subclassify the transverse component. And this should only take a couple of seconds to make a call: transtectal, juxtatectal, or infratectal on the location of the transverse. Transtectal, 2/3 of you selected. Juxtatectal, about 1/3, and one person or 5 people went for infratectal. Well, if you look through here, right, the easiest way is probably to look on the ischiopubic segment, and we can see that there's a small component of roof here adjacent to the cotyloid fossa, and so we know that the correct answer for this one would be a transtectal, and so we have selected transtectal transverse posterior wall, and actually it's a multifragmentary posterior wall. The 3D helps us confirm that what we're seeing here is the transverse with a multifragmentary posterior wall. And so this is operated through Coker-Langenbeck approach, prone, single surgical approach with reduction and fixation. And we can see here the immediate post-operative Judet views of the reduction of the transverse and the posterior wall component. Small gap in the anterior portion of the transverse fracture that we can see there in the roof, which is not desirable, but it's the way it ended up.